Good afternoon, everyone. First of all, let me thank those who have joined online to this webinar. This is the fifth webinar in the series of standard treatment workflows, which have been prepared by Indian Council of Medical Research. This is one of the mission mode project which ICMR initiated in 2018. And we could develop the volume 1 and volume 2 of STWs of different specialities. These standard treatment workflows have been prepared keeping in view of the various conditions which are common in OPD and which are common in IPD as well. So these STWs have been prepared with an objective to strengthen the primary, secondary, and tertiary level care physicians who are imparting the day-to-day management of the patients. Some of the conditions which can be managed at even primary healthcare settings get referred to the higher centers because of sometimes lack of awareness of the updated information, or sometimes they think that these are the conditions which have to be managed at a higher center of level. So these have been prepared keeping in view of the simplified version of the available textbook knowledge, the available scientific evidence across the globe, and so various associations of the Indian and the international societies. So these standard treatment workflow are basically one pager in size. And so far, we have developed the STW in conditions like cardiology, the ophthalmology, the dermatology, the neonatology, the urology. And one of the conditions which we developed the STWs are in the area of orthopedics as well. As we all know that the conditions in orthopedics which are common in nature are osteoarthritis, supracondylar fracture of humerus, septic arthritis, very common conditions which can be manageable at various levels of healthcare setting as well. So keeping all those things in mind, that whatever the resources available at each facility, the STWs have been prepared so that even a physician sitting at the remote area or the physician sitting even at a tertiary care hospital setting, and as well as the postgraduate students also, they can be benefited after going through these STWs. We have our collaborator with us in developing these STWs, National Health Authority, who is looking after the reimbursement packages under the Ayushman Bharat scheme and Pradhan Mantri Jan Arogya Suraksha Yojana, as well as the WHO India country office is a partner with us. And the topics on which we have to develop the STWs are usually by and large driven by either NHA or sometimes the experts or some various associations, and the request for topics keeps coming to us. These standard treatment workflows have been primarily utilized at a peripheral healthcare settings, either in a poster form or into the web app or into the mobile application. So these standard treatment workflow, we have a separate dedicated website at ICMR. I'll put up the ICMR link to that website in the chat box. Those who want to download this application, the STWs, they can download it. And in the mobile app also, they can be downloadable. The salient feature of the STW is that this is a summary. They have not been something not newer evidence, this is available evidence, but facilitate the doctors for the management. Today, we will be dealing with the two important standard treatment workflow in the area of orthopedics. And we have the experts from the discipline, Professor S.C. Goel, who has been working with the Varanasi Hindu University. We have Dr. Arya, who is working as a professor in RML hospital. And then we have Dr. Vijay Jain, who is also working in RML. Besides that, we have the other team members, Dr. C.P. Pal from Agra, Dr. Vineet Sharma from KGMU Lucknow, Dr. Sanjeev Gaur, Gandhi Medical College, Bhopal, Dr. Rajashekharan from Ganga Hospital, Chennai, from the private facility, because some of the patients for each management, every management, they mostly approach the private practitioners also. So the standard treatment workflow, they are of much use to the physicians, be at a public care facility, be at a private healthcare facility. So not to take, and we have Dr. Alok C. Agarwal also, who has also joined the meeting with us from AIIMS Raipur. So the experts who have preparing the STWs have been taken from all over India, so that we have a wide coverage, wide representation of the experts, and their mutual experiences of seeing the patients is vast. around 30 to 40 years of experience they have been doing it. And they have been deliberating upon the discussion that what should be there into that STW that which can be benefited to the patient outcomes. So before I go to the experts for their remarks and really telling all the audience about the two STWs which have been the volume 3, we have Dr. Sudha Chandrasekhar, who has been with us throughout the journey of volume 1, volume 2 from National Health Authority, telling us that how these STWs are utilized and how the state health authorities are being benefited from these STWs. Dr. Sudha, ma'am.
Thank you, Dr. Ashu, and all the experts who have been a part of our NHA benefit package development also who are here. I think this is a very good initiative which has been started since 2018, and we have been associated with ICMR on this initiative since 2019, when we decided to utilize the kind of the STWs developed in the first volume as a method to also improve our quality of care delivery under the scheme at the hospital level, and also the processing team, because we have various claims that are being processed. So they need to follow a methodical way of ensuring the justification of those conducting those procedures and ensure there's no variation in that. I think in that background, we worked closely and with the experts and used the template of the STWs that have been developed and customized it for the benefit of the National Health Authority, the PMJY scheme, and integrated it within the IT system. I think most of the times we have a lot of guidelines, but the adherence to the guidelines and the implementation and the uptake of those guidelines get limited. But when we introduced it and integrated within the IT system, it made sure that the hospitals and the treating clinicians are reviewing those guidelines and ensuring that the adherence is happening, and they are submitting the kind of justification and documentation which can actually ensure appropriateness of the care that is provided. So in that way, that gave us a lot of confidence, and we have been interacting with all our hospitals and orienting them and making sure that this is something that they need to follow. So this was for the existing packages, but also whenever we are developing now, the new package development is also based on the STWs. So when we understand that what are the components that needs to go into the package and the kind of cost and the pricing that needs to be done also has to be in coordination with the kind of service that is being provided. So in that way, we are using the STWs both for refining our packages and the pricing, but also ensuring the quality of care and the reimbursement, so that in case those are not met, then there are queries raised by the processing team and also reviewed. So it is mainly helping us for faster claim processing and payment to the hospitals at a much, without delay. So in that sense, I thank all the experts who have contributed to the development of STWs, and also for reviewing the guidance document that we were preparing and sharing with them for approval before those are integrated. So thanks, Dr. Shu, and we would definitely continue this association as we go ahead.
Thank you, Dr. Sudha, for telling us that how these STWs are being utilized at a national level. And I hope that the relationship and the continuation and collaboration will continue further as well, because we are developing on the STWs. Today, we had a discussion about total hip replacement and a total knee replacement and other conditions which are very common, like low backache. So very soon we will be developing these STWs for the use of the physicians and benefiting the population. So now I will request Chairperson Professor S.C. Goel to give his remarks about that, how these STWs have been prepared, what he thinks that could be the utility of these STWs, what are the discussions. Followed by, first we will have the septic arthritis, Dr. Vijay, and then we will discuss the supracondylar fracture humerus. And just to tell the audience, if they have any queries about the STWs in general or specific to the orthopedic STWs, please put up the queries either in the chat box. We will note it down the queries and get back to you. Or else in the end of the webinar, we will allow everyone to raise hands and put up the questions to the experts. Thank you, and Dr. Goel.
Thank you, Dr. Ashu. This has been an ongoing exercise we have been doing for the last 4 or 5 years. The basic thing is that in our country, the idea of the healthcare is primary, secondary, and tertiary, 3-level courses there. And a doctor who is sitting in a primary health center may be only an MBBS doctor or maybe belonging to one of the specialties, and he has to see all the patients. The basic thing is that at primary level, he should be able to provide a first aid. He should be able to do a basic treatment, and if required, he must be able to understand that he has to refer this patient to a higher center. So where are the problems? What are the conditions where he has to refer immediately? That he must know, and what he can do at that level with limited resources. We understand that many of these centers will not be having an X-ray facility also, or not having any operative environment also. So he has to understand, after providing basic care, he has to refer it immediately to secondary center. And whatever can be done at secondary center will be done there. And if it requires a further more care, then patient must be referred to tertiary care center. So this is the idea by which we have developed these STWs. So what flow is there? What should be the standard treatment at the primary level? What should be the standard of treatment at the secondary level? And what should be at the tertiary level? So that patient gets the full benefit of the healthcare facilities and doesn't suffer. With that in view, we have formulated few of them who have been already published, which we will discuss today. And furthermore, conditions we are going to discuss in future, about which we had a preliminary meeting today morning also. And then in future, we will be coming out with the STWs about the total hip replacement, total knee replacement, osteoarthritis, low back pain, and other conditions. So with that, we will go further. Thank you.
Septic arthritis and display.
single page open कर दो 160 कर दो जो
Coming back, so this is one standard treatment workflow which has been there on the screen. You all can see is on the septic arthritis. This is a condition which is, I think, very common and which requires the physicians to know all about it. So we have Dr. Vijay Jain with us to tell us that I mean, what are the contents and what are the things which you can be going through.
So good afternoon, everyone. I'm Dr. Vijay Jain, and I'm thankful to Dr. Ashu and Dr. Goel for giving me opportunity to read this. And basically, these STWs are made by the experts in orthopedics, and these are also based on the various guidelines available nationally and internationally. And based on the consensus, we have made this septic arthritis, and irrespective of the joint involved, whether it is a knee, hip, or elbow or shoulder, any joint, we have to first identify the symptoms. The patients usually present with a fever, which will be mild to moderate to higher grade, and then will have pain, swelling, and inability to move the joint. It is in smaller children where they will not be able to express their problems. There may be malaise, listlessness, irritability. There may be poor feeding, immobility, and joint dysfunction. So first we have to take out the history, and then if we examine the patient, then we can have patient with the swelling, erythema, tenderness of at the joint line, or it may be diffuse tenderness. Then there will be a painful limitation of the joint movement, or patient may walk with the painful limb in the OPD or in any primary healthcare center. So these patients may or may not appear acutely toxic and ill, And because in some cases, like in cases of malnourishment or if the patient is immunocompromised, the signs are usually masked. So we have to take detailed medical history in order to look out for the primary focus of the infection, and also including history of antecedent mild trauma. So because the history, based on the history and examination, the diagnosis is crucial, because the time is a limiting factor in the cases of management of septic arthritis, because any delay in diagnosis in such cases can cause morbidity, or the prognosis can be worse for the patient. So can we move? So now once we diagnose based on the history and examination, it is essential that we should have some investigation, which could include the hemoglobin, hemograms, and some inflammatory markers such as erythrocyte segmentation rates and C-reactive proteins. We have to take blood cultures, and then the joint fluid aspiration is important, and this should be sent for the gram staining, and also for the aerobic anaerobic culture and drug sensitivity testing. So these are the essential tests, but some of the desirable tests which may be advised. For example, plain radiograph of the affected joint. Ultrasound is very helpful. Sometimes we have to look for the effusion, and then it will help in taking the samples, help also in taking the samples out. Then Doppler is needed, because the septic arthritis patient may develop deep vein thrombosis. So this is an important investigation, can be asked. Then patient has to be seen for the any renal and liver function test. In cases of immunocompromised patients, or otherwise we can ask for the hepatitis to rule out the hepatitis C, hepatitis B, and HIV infection. Then we have to also see whether the patient is having any diabetes. For that, we have to go for the blood sugars. Then the synovial fluid culture, synovial fluid can also be sent for the fungal and microbial staining, though in acute cases it is rare, but we have to, we can send it for that. And also the synovial fluid can send for the polarizing microscopy to look for the other causes of acute pain, and also for the look for the synovial sugar and protein levels, because they can be the sugars can be down and protein can be raised in cases of pyogenic infection. So once we send these things, then we have to suspect when it is a septic arthritis. So if the aspirate is cloudy and purulent, then one can suspect, or there is a synovial fluid blood count is raised, or there is a higher neutrophil count more than 90%, or the gram staining is positive, or the blood sugar level, the synovial sugar is 50 milligram per deciliter less than the serum glucose level. Then these are the things which can clearly say that this could be the septic arthritis. So some of the tests which are optional and can or cannot be done. For example, the serum prolactin level can be increased in cases of septic sepsis in the body. So it is not reliable marker, but it can be done. Then contrast MRI can be used sometimes in order to rule out any bony changes. So now coming on to the management part, suppose we are sitting in a primary care. And if the patient comes and you have a clinical history, you have an examination, and you are suspecting that it is a case of septic arthritis, just what you have to do is give adequate analgesia, immobilize the part. And if you think that the patient will take some time to reach the next center, for example, 2 to 3 hours, then you can start with the first dose of IV broad spectrum antibiotic. Otherwise, there is no need of starting antibiotic if the patient is reaching to the higher centers directly. Because in the higher center, first thing we do is, other than giving adequate analgesia and immobilization, the part is taking the aspirate of the joint. So these are the important things. One must learn these things, that antibiotic should only be given if you have any certain time period. Otherwise, there is no need of giving any antibiotic, because once we start antibiotic, there are chances that the subsequent culture will come negative. So once the patient is referred to the higher center, then again, if the patient comes directly to the higher center, then you can give analgesia and immobilization along with the joint aspiration for the gram staining and culture sensitivity. the radiograph and ultrasound of the affected joint can be taken, and the patient should be started with the IV antibiotic. After we can take cultures, and then this should be sent for the culture and sensitivity report. As mentioned, the surgical treatment is usually required in these patients because we have to go for the either drainage of the pus and joint debridement and then lavage. If suppose the patient is not is requiring a repeated surgery, or he requires another surgery, then there are chances that there is a atypical organism. So what in a normal scenario, what we do is we start antibiotic after taking cultures, and then we do the joint debridement properly, and then we keep patients on IV antibiotic for 2 weeks, and then we can shift toward to the oral antibiotic for another 4 weeks. So the conversion to the oral antibiotics is based usually upon the clinical improvement to the patients, fall in the inflammatory markers, and resolution of the systemic symptoms. Once these are going down, then we can switch the patient to the oral antibiotic. So also sometimes it is needed that if the patient is not responding, then we can consult the patient with the microbiologist also, and we have to also manage the complications such as the deep vein thrombosis, osteomyelitis, or pathological fracture that can occur in patients, and these should only be done at the higher centers. So if patients have a definite diagnosis, we can do it. If there is a no definite alternative diagnosis is made, then what we can do in the primary center, we have to refer patient immediately to the higher center after giving adequate analgesia and mobilization. And in the higher center, again, we have to aspirate the joint, investigate the part, and if it is a septic arthritis, then we have to treat as the protocol I have discussed with the septic arthritis. But if there is a no definitive alternative diagnosis is made based on the history and clinical examination, we have to think of other diagnoses which can mimic the septic arthritis, for example, inflammatory arthritis, joint crystal arthritis like CPPD and gout or hemarthrosis, or patient have some trauma or bursitis or cellulitis. And sometimes the transient synovitis is a close mimicker for the septic arthritis, but has to rule out and then treat as appropriate. So now coming on to the surgical treatment. The surgical treatment, I said, it is done in each and every cases. It should comprises of the surgical decompression, that is the arthrotomy, and we have to do the thorough saline lavage. And some clinicians put suction drainage and some may not. So based on this, and if suppose patient is if the surgery is contraindicated because of any means, patient is not able to fit for the anesthesia or OT is not available at that time, or some other reasons, then we can also do the serial aspiration and lavage under the fluoroscopic guidance or ultrasonic guidance. So for surgical decompression, we always see the clinical improvement. If it is there, then we can switch over to the, then we continue the antibiotics as protocol I have discussed. If patient has not improved, if no improvement at all, then we can re-evaluate patients clinically and radiographically. These patients may require repeated arthrotomy, debridement, and repeated cultures for the prolonged period of time. Then we have to take consideration of the infectious disease experts like microbiologists, and we have to also think about the atypical infection. But sometimes in between the patients are there which have some responses and may not respond. In those cases, either our diagnosis is inadequate or incorrect. Then incorrect causative organisms may be present. Then in cases we have to stop antibiotic and we have to do reculture and start antibiotic as per the next antibiotic report. Or we have to modify antibiotic treatment. For that, we have to seek microbiological advices, or we have to think of if there's any other area of focus of infection is present in the body. And certainly in cases of osteomyelitis, we need to have further review. So in summary, I have to tell you that the timely treatment of the patient is required. First and foremost thing is to make diagnosis clinically. Many times it's a clinical diagnosis. Then if patient is at the higher center, the aspiration is important. If it is in the primary center, just immobilize and give analgesia. Don't try to give much. If patient can reach within time of a higher center. Thank you very much.
Thank you, Dr. Vijay. And we have the references below the each STW if you want to have some, higher consultation and some detailed guidelines. So these are the 4 references from which these evidences have been taken, which has been said about. So thank you, Dr. Vijay, for telling the audience about this septic arthritis management. Then we now move to our next STW, which is a common condition in pediatric age group, the supracondylar fracture of humerus. So for that, I request Dr. Goel to.
Can you go to my slides?
Yes. I'll display it. वो screen share को बंद करो वहाँ पे.
Yes. So, full screen, sir. View. Go to the view. View is many. Okay. Next slide. Next slide. Or give it to the sir. Okay, नहीं हो रहा.
ये slide वहाँ से share कर दो.
तो उसी से दिखा देते जैसे डॉक्टर ने दिखाया उसी को लगा दीजिए.
अब presentation
और
क्या है?
like this only.
क्या बात है?
So friends, I will talk about supracondylar fracture of the humerus in children. So this is a very next slide. This is a very common condition in the children, and 16% of all pediatric fractures is supracondylar fracture. And this is very important also because complications are many. Malunion is very common in this fracture, and patient will end up with the cubitus varus, and there are neurovascular complications and compartment syndrome. Hence, it is very important to have a good, proper treatment of this fracture. Next. This is the STW we have prepared. It's not coming well, but I'll discuss the same in the next slide. Next. So, the clinical presentation, what the injury is usually fall on the outstage hand and is commonly seen in children between 5 to 7 years of age, though any child can suffer and fall with the outstage hand. Patient comes with swelling in the elbow area. The swelling is there, pain is there, and there's loss of movement. The child is not moving the limb. He has a loss of function of the elbow joint. And with that, they present to usually. Next, please. So actually, radiologically, we can classify them into 3 types. Type 1 is an undisplaced fracture. Type 2 is a displaced fracture where there is an intact posterior portal or a posterior hinge is intact. And type 3 is that which is totally displaced. And the treatment will depend on the type of displacement. Next. But when you see the child comes with the swelling, there's a deformity, which may be any, because it depends on the position in which child is keeping the limb. So the deformity occurring at the time has no value. It can be varus, valgus, or any of them. Ecchymosis, the presence of ecchymosis where the redness is there is of a sign where it might be a massive bleed inside due to muscle rupture, or sometimes arterial bleed may also be there. And there's a limited motion, active as well as passive motions are restricted because child is in severe pain. What we have to see here is basically, is there any distal neurovascular deficit? because when the fracture occurs in supracondylar area, it is just above the epicondyles of the humerus, and the proximal fragment, there is distal fragment displayed posteriorly. The proximal fragment comes anteriorly naturally, where it is in close contact with the median nerve and the brachial artery. And any of them can be damaged. And that is why we have to examine the nerves as well as vessels properly. For vascular examination, we have to see the radial pulse and also how much is the vascular perfusion in the fingers. Radial pulse is good, then probably there is no vascular injury. But even if radial pulse is missing, then we have to see the vascular perfusion distally. And if perfusion is good, then probably it is not at risk. So a well perfused limb, in perfusion we will see that it is warm and pink. While if it is poorly perfused, when you press on the nail bed and then leave it, it will be cold and pale. If we are suspecting a vascular injury in these areas, then it is an emergency and the child must be referred to a higher center where vascular care can be done. Among the nerves, we examine the median nerve, which can be very well seen by asking the child to flex the fingers like this, and there is a pointing index. There may be radial nerve injury, which can be seen by the wrist drop, or there might be ulnar nerve injury. So these nerves must be examined carefully for sensory as well as for motor functions. Next, please. Now, X-ray is important here to diagnose. In primary health center, X-ray may not be available. But wherever it is available, X-ray must be taken in AP view and lateral view both. And that is how we'll see that in AP and lateral view. Sometimes when the fracture is minimally displaced or undisplaced, there might be doubt. And then we must take a comparative view of the opposite elbow and compare both the elbows whether there is any fracture. In case of vascular injury, if it's available, then Arya Doppler or angiography can be done, but usually they are not required. Next. Many times child may come with an open fracture, where part of bone is protruding out. Now these are the cases where maybe having vascular injury or nerve injury also. But basic thing here is mainly potential contamination, because then this may lead to infection later on. If all the facilities are not available, even then a primary care should be done for this open wound. Patient should be given injection of tetrodotoxide. He must be given good analgesia so that he remains pain-free. For this protruding wound, liberal saline wash must be done. All the debris, all the divisible dirt must be removed, and then it should be saline dressing should be put and a splinter should be applied. A first dose of antibiotic, the broad spectrum antibiotic should be given after the first test dose, and patient after splinting should be sent to a higher center. The splinting may be in many forms, like Cremavire or wooden splint or other things. Once it reaches the secondary center, then we have to, if the patient has come directly, then again we have to do all those things, and then we have to treat it as an open fracture. Next, please. Now, if it is a closed fracture and X-ray is not available at a primary care center, then what we have to do? We have to do a pain management, give the analgesia to the patient, give a splintage, which may be in form of a triangular sling, a lateral elbow sling or lateral elbow splint, or well-padded molded Cremavire splint. Some type of splint will be available in a primary health center also, and that should be given in the position to form. One should not try to manipulate the fracture at that level if X-ray is not being seen, and then you should splint in the same position. If vascular injury is suspected, then patient has to be treated in emergency and must be referred to higher center immediately. But even otherwise, this fracture has to go to a higher center. Because in that higher center, secondary tertiary care, X-rays are available, then we take X-ray in both the views as said earlier, and then decide what has to be done. Next, please. Now, if it is a type 1 fracture, which is a undisplaced fracture, and X-rays are available. It may be a CHC or it may be PHC, and patient comes with an X-ray. Then most of the cases can be treated only by immobilization in a slab in 90 degrees of flexion. And this fracture will unite in about 3 weeks to 4 weeks of time. That much immobilization is required. The basic thing here is the child must be able to move the fingers very, very well. The slab should be so applied, there is no hindrance to the movement of the fingers at metacarpophalangeal joint. But if the swelling is too much, then you may not be able to flex up to 90 degrees. Or if you flex, you will find the radial pulse becomes feeble or absent. In such a case, we should not flex it, should remain in semi-extended position until the swelling subsides. And then the patient is followed up again at 1 week, taken another X-ray to see whether there is any displacement. This is a very important X-ray to be taken because sometimes as the swelling subsides, the fracture may displace, which was undisplaced initially. Now, if it is a type 2 fracture where a posterior hinge is there, usually reduction is not difficult in these cases, but reduction has to be done under anesthesia and radiological control. Most of the cases, close reduction will be possible, and that will be done only by flexing the elbow, and we have to give above elbow plaster cast. Again, the same thing, we have to see whether the radial pulse becomes absent or not. If by flexing the radial pulse is absent, we should extend 10 degrees from that level and give cast in that position with pronation of forearm. Otherwise, 90-degree flexion is a desirable position. Patient should also be watched for distal neurovascular deficit for next 24 hours, because sometimes the swelling may increase within 24 hours after applying the plaster, and patient may now get features of median nerve or radial artery problems. So patient has to be followed again for X-ray also at 5 days for redisplacement when swelling subsides. That is also possible, it may redisplace. Sometimes it is possible that this fracture is not getting reduced even with anesthesia because of swelling or other things, and reduction is not being achieved. Then there is no harm in doing an open reduction and pinning. The reduction is the most important thing here, and we must see that proper reduction has been achieved. Next, please. Now, when the fracture is grossly displaced, it is type 3 fracture where there is no contact between the two fracture ends, or there is a fraction type of fracture, that is when the displacement is the opposite side, or there is a medial column collapse. In these cases, most often operative treatment will be required, which is naturally can be done only at tertiary level. If there is no neurovascular deficit, then we can do a close reduction and percutaneous pinning of K-wire can be passed like this, seen in the X-ray. In cases where neurovascular deficit is there, we may opt for open reduction, where we can examine the brachial artery and median nerve and pin it under direct vision. That is required in many cases where neurovascular deficit is there, or where close reduction is not possible. If there is a nerve injury but vascular injury is not there, we can observe, because nerve injury in these cases may be only neuropraxia, and so we can reduce the fracture if it is reducible and observe it for the recovery of nerve injury for next 3 weeks, and most often the nerve injury may recover. But if the neurovascular injury is there, then definitely the patient needs to be referred to a tertiary center. Close reduction is done in those patients where we find in the decreased perfusion, the vascular problem is there, then close reduction can be done so that pressure on the artery is reduced, because it is the bump, it is the proximal fragment of the fracture which is protruding, which is causing pressure on the artery, and after reducing the fracture, that pressure will be reduced, and so this vascular problem may be treated. Next please. This is how we see for the reduction in both the views, AP and lateral, the fracture must be aligned normally. Next please. These are the signs of red flags or signs are there. If we find there is a pulselessness, pallor, pain, paresthesia, and paralysis, and skin is cold, and there is a painful passive setting, you stretch the fingers passively, extend them, and they are painful. These are the signs of impending compartment syndrome, or what is known as Walkman's ischemia. And these patients may require urgent fasciotomy. So this is again a dire emergency, and patient must be referred immediately to a higher center where a fasciotomy, if required, can be done. Because here it is not the vascular injury only, it is now the muscles and nerves, everything is at risk. And if this ischemia is continued, compartment syndrome ensues, then patient will have fibrosis, muscle necrosis, which ultimately will lead to fibrosis and a Walkman's ischemia concept. So this thing must be seen very carefully, and if there is any sign like that, the patient must be urgently referred. Next, I think that's it. So that is in nutshell about supracondylar fracture. We have seen that in a primary health center, if X-ray is not available, the patient must be given anesthesia. Plintage has to be sent to a higher center where X-ray is available. Once the X-ray is done, then we have to see about the type of displacement. In grade 1 and grade 2, it can be reduced very well by close means. And grade 3, where most of it will require an operative intervention, maybe it will be close reduction or open reduction with internal fixation by K wires or pins. The main problem is when the vascular ischemia is there, and when there are these red flag signs are there, then we must treat them urgently, refer them urgently to a higher center where, if required, a fasciotomy can be done.
Thank you, sir. I think very nicely both the experts have explained that these two orthopedic conditions, if they reach well in time with the primary healthcare setting, so we can do a much benefit conditions, and at least the referrals can be timely done if they know about the signs, symptoms, and the red flags. So thank you, Dr. Vijay and Professor Goel. We have Dr. Arya with us, and we have can have some questions in the chat box, or you can have the hands raised. You can allow all to raise the hands, and if they have any queries, you can just put it to the experts. Till they put up the experts, I asked Dr. Arya if they have anything to say about its utility and anything about the practical.
These two problems are very common in orthopedics. A lot has been written both in textbook and journals. However, as a committee member, we have tried to streamline. There are a lot of queries and a lot of controversial issues in both the topic. After debating amongst our experts, we have made a middle path regime and made everybody to understand that at least these are the standard treatment which should be followed. In a tertiary center, primary center, and secondary center, these are the goals we should achieve, and we should not try to neglect. And time frame again is important in both the areas. As we have said, red flag sign is the urgency where one should wake up, work, and refer them very fast, because delay in time would result into very poor prognosis. There is sometimes non-functional limb or joint. Secondly, whatever controversy or advances are coming, we are open to all. This is not the final draft. Maybe possibly every year or 2 or 3, the committee will check again and modify treatment as and when new things will come in the knowledge and in the journals. That is what we have to add.
Yeah, thank you, Dr. Arya, for raising this very important point. And just to let the audience know that these are the STWs developed and published in July 2020. So we have down the line 2 years, and if any new evidence has come up in the knowledge of the experts and even in the knowledge of the viewers also, so they can share it with us and we can do the updation. So experts are totally keen into it and they're keeping a watch of any new evidence. So that will be updated as and when it comes up. So we have one query from Dr. Santosh Kumar. What should we do if a child comes within 3 days old trauma with pulseless hand?
This is quite common, especially in, I suppose, peripheral India, where child reaches to primary center or secondary center quite late. However, child coming with 3 days old injury should be treated as promptly as possible. As the protocol says, we should have X-ray done. In all such cases, the added complication of pulselessness is there. In such scenario, one should try to achieve vascular surgeon opinion, try to do Doppler if possible, angio, see the level of injury, and of course, because it is old, there's always a compartment already set in. Possibly, one should do fasciotomy, and whatever possible injury one can prevent, can try. Second thing, these kind of things may not recover completely. Some permanent injury has taken place, especially the nerves. Nerves are very sensitive, and within 6 hours time, nerves become almost irreparable damages to it. So in such scenario, palliative surgeries are recommended. However, first aid this should be given, fasciotomy should be done, fracture should be fixed, and limb should be mobilized, and continue observing as per the complication which appears and need to be managed accordingly.
You ask the further questions.
Should I try close reduction in emergency, or can we go?
Dr. Santosh, you can unmute yourself and ask the questions in person.
An opinion. I think one should try reduction immediately, because if the fragments are lying apart and they are causing kinking of the vessel, that should be attempted in emergency, because getting a vascular surgeon to the job will take some time. So even in the primary setup, if the patient comes to you and if you are aware of the maneuvers, one should attempt and try to do at least further injuries, damage to further vessel may be prevented. However, after 3 days, there is already a thrombus which is already found in. This require a vascular surgeon interference and thrombectomy possibly if needed. However, at orthopedics level, one should attempt reduction and then take opinion. If there are some
Wari Sharif from Patna is asking, can fasciotomy be done after 3 days?
well, there are very limited chances that we may gain anything. However, as I said, try to preserve whatever left. If muscles are still resilient and there is whatever supply is left, one try to preserve. And as I said, irreparable damage, you cannot come back. But whatever repairable, because they're associated edema, and if you're able to do fasciotomy and get some relief, somewhat, partly if the muscle has recovered later on, it's always a boon. So one should always try.
Dr. Gaurav wants to know that if there are any signs of compartments indicated supracondylar fracture type 3 and we don't have plastic surgeon for vascular repair, then should we do fasciotomy and fixation of fracture before referring for the vascular repair?
If the vascular surgeon is available within the campus, I think we should do combined procedure. And should be done simultaneously. However, in secondary like district hospital, vascular surgeon may not be available. However, orthopedic surgeon may be available. And referring from orthopedic surgeon to secondary center to tertiary center, if it is taking time, one should reduce, pin it, and then refer. Because as I said, thinking it should be reverted is some injury, further damage, further stimulus to thrombus formation can be taken.
There's always a chance of secondary, even if you do primary or secondary delayed.
More chances in case of secondary, because there is necrosis of tissue around. So there's always a possibility of secondary infection in cases of delay. However, one has to take chance and of course need to treat the complication.
Any more queries from the participants? Can unmute yourself and raise the question to the expert.
Just wanted to make sure that fasciotomy is not simple skin incision. It should be tightly done, deeply done, including the epimysium of the muscle. All muscle, all fascia, everything to be released and released in, they should not be choosy or should not use small multiple incision for fasciotomy. It should be a single large to decompress completely, because whatever chances are there, these chances are there to complete decompression. Half job done is actually a bad job done.
Even if there are questions which are there in your mind and later on comes up to the in your mind or any while accompanying the procedures and all that, you can always write down to ICMR. I can share the email ID on which you can put up your questions later on, and we will refer it to the experts so they can always answer to those. So I'm just sending my email ID, so which is ICMR-STW. STW-HQ.
Till the time we are coming down to giving you the link, just wanted to again highlight something about supracondylar fracture, where we had shown an X-ray from pinning from medial and lateral both sides. Pinning from the lateral in a closed reduction is safe.
Yeah.
However, when we are putting pin from the medial side, I would always recommend a small incision, see the ulnar nerve, and then put your pin. Because putting blindly, especially the person who are resident and who are in a learning curve, there is a possibility of injuring, iatrogenic injury to ulnar nerve. In such scenarios, small incision on the medial side, see under vision, and then put a pin. It is always better to pin from the both sides because they are rotationally more stable construct. Pinning multiple from the lateral side is also rotationally stable. However, it should be divergent. It should not be parallel, preferably. And septic arthritis, there is new people who are doing arthroscopic debridement. There is nothing wrong in arthroscopic debridement. However, the surgeon should be well experienced, because arthroscopic debridement, what purpose of debridement is to do complete job and completely drain out whatever pus, lavage, with plenty of fluid, and do synovectomy, whatever thickened synovium, it should do subtotal synovectomy. If you are not trained enough in arthroscopy, it is always better to do open arthrotomy rather than going mini open or arthroscopic in such scenario. Every minute count in both conditions. In enzymes, if it is delayed, septic arthritis, the toxic enzyme causes chondrolysis, resulting to poor result. And in the supracondylar, every minute lost, especially the vascular and nerve injuries, would count for the final result.
How we can do
So this question has come, how we convince the patient we don't have vascular surgery, we are going to fix it. Now, what else you can do? The only thing is, in case there is vascular surgeon nearby, where he can reach in 1 hour or 2 hours, you can straight away send him away. Don't reduce it at all. But then you have to tell the patient that, okay, this is the cause, this is the fracture, we are going to reduce it. It may or may not recover. You require further treatment consultation with a vascular surgeon, for which you should go to the required place. Because getting a vascular surgeon in a peripheral area may not be possible, we understand that. And in that case, you cannot neglect the patient. But yes, of course, an informed consent must be taken.
Yeah, I think that's very important, mainly that the patient has to get some treatment to avoid the further damage
Yes.
to the,
That is the basic
yes,
thing.
that's the basic aim. So we are benefiting the patient.
There are limitations always. However, the best treatment option at your level should always be tried.
So if there are not more any questions, so we can close the session. And before we close, I thank experts, Professor Goel, Dr. Arya, and Dr. Jain to be with us, and the other team members from the orthopedic STW development group, Dr. Alok Agarwal, Dr. C.P. Pal, Dr. Vineet, Dr. Sanjeev, Dr. Rashekharan, and Dr. Devendra, who had been kind enough to be with us throughout the journey of developing STW, and especially joined during the webinar and deliberated in these two discussions. And thank you, Dr. Sudha, also for joining with us today for telling us from the NHA perspective. Thank you, everyone.
Dr.
So
Vineet
we,
there, Vineet joined.
so we closed today's session. Thank you, everyone.
And
And for all. And for all.